Hi, everybody. My name is Tom Fusillo. I am a second-year internal medicine physician. I wanted to make this video just as a kind of an intro to the non-Hodgkin's lymphomas. Many different types of lymphoma, Hodgkin's, non-Hodgkin's, and within non-Hodgkin's, there's many, many different subtypes. So this video, I kind of just want to talk about the basics of non-Hodgkin's. How can we sort of start the workup for that, staging, introductory things like that. And then from there, I have some other videos that you can probably go into on some of those subtypes. So I hope you find this helpful and enjoy.
All right, so let's talk a little bit about the non-Hodgkin's lymphomas. We'll start off by talking about some of the subtypes and the epidemiology of these. And so when it comes to the subtypes, first of all, let's look at what subtypes really have. So over here, pie chart of all of the lymphomas that you can really have. You have Hodgkin's disease, non-Hodgkin's, some other disorders like plasma dyscrasias, ALL, CLL. The non-Hodgkins, as you can see here, make up the vast majority of these neoplastic processes. Almost 2/3 are non-Hodgkins. And within non-Hodgkins, many, many different subtypes. And even within these, there's some more. So, for example, diffuse large B cell has maybe 15 subtypes within just there. So many, many different subtypes. And when we look at non-Hodgkin's lymphomas, one of the things we're always asking is the cell of origin. These are primarily going to be either B cell or T cell disorders. Now, there's also some non-Hodgkin lymphomas that are NK cell or natural killer cell disorders, and those are usually under the T cell domain. If you're interested in learning more about DLBCL or diffuse large B cell lymphoma in particular, I have a few videos on that you can check out. My goal eventually is to come out with some video series on a handful of these, especially the more common ones like follicular, maybe MALT, mantle cell, marginal zone, things like that. So let's talk more about the epidemiology here. Non-Hodgkin's lymphomas accounts for about 4% of all new cancers diagnosed annually in the US, and it ranks number 6 in both cases diagnosed and in mortality in both men and women, if you exclude breast and prostate cancer. So it's an important disease process in cancer to know a little bit about. Non-Hodgkin's is diagnosed about 10 times more than Hodgkin's lymphoma. It's much more common than Hodgkin's. It's more common in males than females, as well as more common in Caucasian patients and African American patients. And while the incidence of non-Hodgkin's lymphoma increases with age, it remains a common cancer in young people. So don't get a red herring effect by looking at the patient's age and seeing they're a young person, oh, well, they can't have non-Hodgkin's. They absolutely can. And so here are some major risk factors that we're going to discuss a little more in the next slide. But as you can see, the overarching theme here really is immunosuppression as a risk factor. Let's talk a little bit about those associations and risk factors. And the first set of risk factors are going to be the infection associations. There's many. There's some that are a little more high yield when it comes to exams, USMLE, and some residency exams. But the big ones really to know about are Epstein-Barr, first and foremost. Epstein-Barr virus, EBV, is associated with a bunch of different lymphomas, actually including Hodgkin's. So Hodgkin's is on here as well, as you can see. But non-Hodgkin's wise, the main one to think about really is Burkitt's, as well as DLBCL, so diffuse large B-cell lymphoma. Those are some kind of high-yield associations to keep in mind. So HTLV1, associated with adult T-cell leukemia or lymphoma. And then another big association is HIV, associated with DLBCL and Burkitt's. Remember what we said, anything that's going to immunosuppress the individual is going to put them at increased risk for really any malignancy, but especially a non-Hodgkin's lymphoma. And so HIV, you have both an infection and an immunosuppressed state. So you hit the patient twice with that. And then another one that's high yield here is H. pylori. Okay, that's very linked with gastric MALT lymphoma. So keep that in mind. So there are also some diseases and drugs associated with non-Hodgkin's. Again, like we've been saying, you're going to be hearing this theme a bunch when you talk about this, is anything that's going to immunosuppress the individual really is going to be a risk factor for non-Hodgkin's lymphoma. So here you can see the inherited immunodeficiencies, things like Chiari-Akagashi, Klinefelter's, ataxia, telangiectasia, Wiskott-Aldrich, CVID, of course. So here, acquired immunodeficiency diseases, HIV, anything that's going to immunosuppress low immunoglobulins, of course, and then your autoimmune conditions. So Sjogren's, RA, lupus, all are going to immunosuppress the individual. And we can also think of immunosuppression iatrogenically too, right? If somebody's on immunosuppression to treat some of these autoimmune diseases, that's also going to be a risk factor. And then finally, chemical and drug exposures. There's a handful. The biggest really one to know here is radiation exposure. So if somebody's had radiation previously for another malignancy, or if they somehow have radiation exposure from their workplace, definitely a big risk factor. And of course, prior chemotherapy as well, which is a risk factor for secondary malignancy and in many cases, not just lymphomas. We'll talk a little bit about the genetic associations with non-Hodgkin's. Again, there are many, and depending on what kind of level you're at in your education or training, the more or less you may need to know. At the medical student and the resident level, I think the important ones to really keep in mind are 814 for Burkitt's. It's rather high yield, so that's a translocation of the MYC and immunoglobulin heavy chain. Again, Burkitt's, translocation of 814. Follicular 1418, so that's BCL2 and the IgH, or the immunoglobulin heavy chain. And that's also seen sometimes in DLBCL, which I talk a little bit about in the DLBCL video that we have out. And the rest of these, they're important, obviously, if you're going to be working somebody up for one of these. But as far as whether it's in training exam and internal medicine residency or USMLE, not going to be the highest yield. So the main ones are going to be those Burkitt's and the follicular and DLBCL translocations. So let's talk a little bit about the initial workup of the disease. So you have a patient and you're suspicious that they might have a lymphoma or some sort of lymphoid neoplasm. How can we start this process? So of course, you're going to see a suspicious lymph node on imaging, and what's going to prompt the imaging? Maybe you do a physical exam and you feel some lymphadenopathy on their neck, their groin region, whatever, inguinal chain, posterior auricular, whatever chain they have. You'll feel a lymph node, you see it on imaging. And what we want to do then is, of course, get a biopsy. So there's multiple types of biopsies, but the best one and the one that's going to give you the most accurate result is an excisional biopsy, because that really shows you the overall architecture of the lymph node or that lymphoid tissue. A core sometimes is enough to make a diagnosis, and FNA rarely is really going to be enough. So I wouldn't even really recommend wasting your time with an FNA. You really want to get that excisional or core, and that's when you're going to work with your surgery or interventional radiology colleagues. Once you have that tissue, of course, just going to be regular histology. We're going to do karyotype and FISH, fluorescent in situ hybridization, to look for some of those translocations or any trisomies. Your IHC or immunohistochemistry, which can be your special stains to help you determine really what subtype of non-Hodgkin's lymphoma this is, as well as your flow cytometry. So what about the other initial workup that we're going to have to do in somebody who we're suspicious of a non-Hodgkin's lymphoma? So we'll start over here on the left, the H&P, the history and physical. That's really the bread and butter of medicine and the backbone of many diagnostic workups. And what we're looking for here are many things, but the main thing, first of all, is B symptoms. That's something we're always taught about in medical school and residency and training. So what are our B symptoms? Remember, night sweats, fevers, chills, unintentional weight loss. Those are all going to be considered B symptoms. And then on your physical exam, always remember, try and check for splenomegaly. It's not always easy depending on body habitus, but it's a good thing to check for, because splenomegaly can also indicate maybe there's something more insidious going on here. When we're doing some lab work, we're going to get some basic labs, just like a CBC and differential. Make sure it's with the differential, right? Because if we're looking for a lymphoid neoplasia, we're definitely going to want to see the diff there. Your CMP or complete metabolic panel with FOS. Sometimes MAG is not included in the CMP, so you'll get a MAG as well. LDH is a major prognostic indicator, and then you'll see later is included in many of the prognostic indices or scoring systems. So you need an LDH to help with that. Uric acid can be helpful as well to see if there's a lot of cell turnover going on, and do we need to be worried about any sort of TLS if we were to start treatment. If you have a female patient, beta-HED to rule out pregnancy, and a beta-2 microglobulin can be helpful because that's often a prognostic marker as well. In addition, with lab work, we're going to do some infectious screening here. So HIV, as well as hepatitis, particularly hepatitis B and C is where we're interested in, because some of the agents that you may start for treatment of the lymphoma can actually reactivate hepatitis. So We want to be aware if they have status or not. When it comes to imaging, the main thing here is going to be your CT or your PET CT, because you want to stage this person, right? You want to see the extent of the disease and how bulky the disease is. And also, if we don't know what their disease looks like in the beginning, how can we really assess treatment response, right? So that can be done with PET CT and or a CT chest, abdomen, pelvis. And remember to always get that with contrast to help elucidate the tumor and the tumor borders and things like that. I put echo in here. You may not think of an echocardiogram as something that's really important in working up a lymphoma or a non-Hodgkin's disease, but it really is necessary a lot of times, not necessarily to evaluate the disease itself, but to be aware, because when we start some of the chemotherapy agents, they can be cardiotoxic, right? So if you have somebody who maybe they already have a cardiomyopathy or they already have a heart failure with reduced ejection fraction or HFpEF, heart failure with preserved ejection fraction, depending on the severity, some of those chemotherapy agents really might not be an option for them. And then finally, considering an MRI brain plus or minus spine to see if there's central disease may not always be necessary, but depending on what the patient workup so far has looked like, that may be something you might need to image. And then following suit, the additional pathology, in addition to the things we talked about on the previous slide, if we're suspicious of a CNS process or a CNS lymphoma, a lumbar puncture could be necessary if it can be done safely, depending on what the imaging shows. And similar with the PET CT, if there's indication that there could be disease in the bone marrow, biopsy might be needed as well. So let's move on here to staging and prognostication. So staging for all lymphoma, both Hodgkin's and non-Hodgkin's, is done primarily by the staging system called the Ann Arbor staging system. And that's what this is up here, as well as a diagram here to help you understand by looking at it. So the Ann Arbor is 1 through 4, and there's some extra qualifiers like you see here, E, S, and we'll talk about A and B as well. We'll just go stage by stage just so we can get an idea. So stage 1, you have involvement of a single lymph node region or a single extranodal site. So when you see E, that stands for extranodal. So if you have a patient that has disease outside of a lymph node, they're going to have an E tacked onto their staging, right? So you see here, stage 1, looks like this person has some disease in their cervical or their posterior auricular lymph node chain, but nowhere else, right? So this would be a stage 1. Now, let's say this person didn't have it in this chain, but let's say they had it in one specific extranodal site, whether it's soft tissue or somewhere around here, that would be a 1E. We move on to stage 2. We see its involvement of 2 or more lymph node regions or lymphatic structures on the same side of the diaphragm alone, or with involvement of limited contiguous extralymphatic organ or tissue, that would be 2E. So as you can see here, the diaphragm is an important border in staging. Same side of the diaphragm, limited disease, limited to the lymph nodes, would be stage 2. Now, if we split that, and now we have some on both sides, we have disease on both sides of the diaphragm, we're looking more at stage 3, right? So stage 3 is an involvement of lymph node regions on both sides of the diaphragm, which may include the spleen or limited contiguous extralymphatic organ or tissue or both. So here they introduce the S qualifier, which stands for spleen. So if you have splenic disease, regardless of stage, you can tack on the S to the end of the stage. And so here we can see that shown in the image here in stage 3. Still only 2 lymph node chains that have the non-Hodgkin's, but different sides of the diaphragm. So that's the difference between 2 and 3 in this image. Same number of chains involved, but 3 has it on both sides of the diaphragm. And stage 4, this is diffuse or disseminated foci of involvement of 1 or more extralymphatic organs or tissues with or without associated lymphatic involvement. So this is basically stage 3, but you also have extralymphatic, extranodal, I should say, disease. So this one, it's in the liver, it's in the bone marrow. It could be in the CNS, although that would also be more of a, just call it CNS lymphoma. And it could be in the spleen. So there's a lot of options here. And so what this is saying over here is you can also, if you wanted to, tack on an A or B at the end of your stage, and that's a symptomologic qualifier. So A stands for absence of B symptoms, and the B is, yes, there is B symptoms. So those are night sweats, fevers, or unintentional weight loss, like we said earlier. And so I'm going to finish this presentation by talking a little bit about prognostication. There are many different types of non-Hodgkin's lymphomas, like we said in the beginning. Some of them have their own prognostic tools, and many of those kind of revolve around this thing called the IPI, which stands for the International Prognostic Index. So the most commonly used one is in DLBCL, which is just the regular IPI that was designed for diffuse large B-cell lymphoma prognostication. You can see it gives you a few requirements that you have to meet, and this gives you a point system. And based on how many points, it risk stratifies you. So things like age, is your LDH high, what's the performance status, your Ann Arbor stage, like we just talked about, how many sites are extranodal, things like that. So let's say you have a patient who's 65 with an elevated LDH. So that would give them 1 point here, 1 point here. And then they actually divide out the stratification based on if they're getting R-CHOP. So let's say our patient is getting R-CHOP. They have 2 points. It's going to be an intermediate prognosis. 4-year survival is about 80%. And most of these really work this way. A lot of them have many of these same criteria. Some of them have additional. Some of them have taken these out. And then they have their own risk stratification systems with that. So we have the CNS-IPI, which is used in DLBCL as well, which gives you basically the risk of DLBCL coming into the CNS. There's a MALT-IPI, which is, of course, for MALT lymphoma. There's a FLIPI, or a follicular lymphoma IPI, so that's follicular lymphoma. And then finally, the MIPI, or MIPI, is for mantle cell. So these are all very useful prognostic tools and can also help you choose treatments as well.
So I hope that was helpful. You learned a little bit about the non-Hodgkin's and lymphomas and how to sort of start the process on working those patients up and staging prognostic factors. If you liked and you want to learn more about lymphomas, I have a series out right now on DLBCL, the diffuse large B-cell lymphomas. So check that out, and I hope you'll enjoy.